Osteoarthritis. Osteoarthritis is a leading cause of disability and has a substantial economic impact. It's a fairly common condition. People now claim that almost everyone after the age of 65 has some osteoarthritis. Thus, it's considered something that is closer to physiology than to pathology. The issue with this condition is that the cartilage is damaged and the homeostatic system of the joint does not cope with it appropriately, leading to bone and synovial remodeling as well as modest inflammation. However, even though osteoarthritis is considered physiological to some extent, there are of course factors that increase the severity and make the onset be earlier. Like we have systemic predisposing factors beside age are sex, it's worse in females, heredity, however, genetic studies have not been convincing. Obesity, increased weight on joints but also due to metabolic condition. Osteoporosis, people with osteoarthritis often have osteoporosis. However, people with osteoporosis have a milder form of osteoarthritis, generally speaking. It is counterintuitively a protective trait because when the bone mass is reduced, it is less maladaptive. We have also hypermobility. Local biochemical factors are joint space, shape, and trauma occupation and selected activities. Classification. We have a primary osteoarthritis and secondary osteoarthritis due to traumas like surgery, major traumas, chronic injury, and occupational arthropathies. We have metabolic diseases like acromegaly and hemochromatosis. We have all the inflammatory arthropathies. In this case, we should consider that whenever we have persistent inflammation in the joints, this is going to affect the metabolism of cartilage, and cartilage damage is the main driving event of osteoarthritis. We have also anatomic causes. Congenital dislocation of the hip, for instance, is not treated early in life, if not treated early in life. Articular cartilage. Since it's the main target, we review the main points of its structure. It's avascular and elastic. It's composed of acellular and non-cellular components. The main components are chondrocytes, it's 1-5% of adult cartilage volume, responsible for the formation, maintenance, and repair of articular cartilage. Despite a poor oxygen tension, limited nutrient supply, and anaerobic metabolism, chondrocytes can still produce large amounts of collagen and protoglycans, the two main constituents of the extracellular matrix component. In the extracellular matrix, we have water 65-80% of cases, the main mechanical load absorbing agent, highly present because the polysaccharides, protoglycans, are highly hydrophilic molecules. We have type 2 collagen, 10-15%, mainly involved in providing strength, where the protoglycans confer elasticity and stiffness on compression. Cartilage is avascular, therefore it gets nutrients and oxygen from the synovial fluid. There is a gradient of nutrients from the synovial fluid to the bone tissue. In addition, we know that cartilage functions in dealing and responding correctly to a mechanical load of compressing forces. Water is going to be squeezed out of the cartilage and will then return once the compression is stopped. There is also an important metabolic event because in this case the nutrients do not enter back in the cartilage just by diffusion, but the cartilage receives the nutrients and oxygen like a sponge. Structural endurance to continuous load is 5-6 hours. And we have also cutting forces, so absorption of the load, elastic properties of the matrix. Lubrication is critical to reduce friction. Osteoarthritis targets. Osteoarthritis targets preferentially some specific joints. The most common joints affected by osteoarthritis are the distal interphalangeal joints of the hand. One of the reasons for this is that we do not move the joint enough to allow the squeezing and pushing of nutrients to reach the cartilage. This may be odd as we said, that weight bearing has an impact, and the joints of the hand don't bear any serious weight. Thus, this nutrient theory explains why this occurs. The tissue does not get the nutrients it requires and gets stiffer gradually. Stiff cartilage is less effective in dealing with the mechanical load and will break more easily. On the other hand, Hip, shoulder, spine, and toes are less frequently affected. Osteoarthritis has a slow insidious onset and mostly affects only one of a few joints, in contrast to rheumatoid arthritis, which is a systemic multi-joint disease. Comparison between normal cartilage and early osteoarthritis. There is a clear disruption of the tissue which breaks into the structure. The overall histological picture is completely different. The first feature of osteoarthritis is a fraying and fibrillation of the cartilage. Evolution of osteoarthritis. You have an initial injury to the cartilage and the cartilage attempts to repair itself. Chondrocytes proliferate with a resulting increase in matrix synthesis. However, in the face of chronic mechanical degenerative forces, degradative enzymes overwhelm the synthetic capability that is not sufficient to restore the tissue, especially given the fact that you keep using your joints to skip damaging the cartilage, and the hemostatic capacity of the cartilage is not able to cope with the persistent stimulation. The net result is too much degradation of cartilage and not enough repair. There is then a stereotypical series of events which occur. There will be an inflammatory response to the initial disruption. This has not yet been extensively studied in osteoarthritis. However, there are clinical trials using anti-inflammatory drugs, and they are effective at least in terms of the pain, not yet clear in their role in the history of the disease. The disruption is unable to be dealt with effectively by the cartilage, and the bone gets involved too. The bone undergoes remodeling, which is again not effective, and can be monitored and detected as discussed later. The synovial membrane is also going to be involved. The synovium is an innocent bystander in inflammation. In osteoarthritis, you will not find the hyperplasia seen in rheumatoid arthritis. However, the synovia does not work as it should, and the synovial fluid is going to change its biological functions. In fact, osteoarthritis patients are injected with hyaluronic acid to try to increase the lubrication of the joint. Osteophytosis. The bone remodeling is performed by the activated osteoblast trying to produce new bone to compensate for the bone loss. However, more bone that is required is produced, and this abnormal bone formation is actually underlying most of the deformities that are characteristic of osteoarthritis patients. One would think that the increased bone production would allow the mechanical pressure to be distributed over a larger surface area, so it should be an adaptive mechanism for the loss of cartilage in the earlier stages of the disease. However, in most anatomical locations where you have this bone formation, it does not have any role benefit in that manner. Typical feature of osteoarthritis is that the space between the two joints gets narrowed, since the cartilage gets damaged and gets thinner. This is also found in inflammatory arthritis. However, we see in the case of osteoarthritis, the narrowing of the space is asymmetrical. This is especially relevant in the early phases of the disease, because the load is not evenly distributed, so the cartilage is going to be more damaged on one side more than the other. This asymmetry is what starts the inflammatory remodeling events that characterize the disease. Osteoarthritis signs and symptoms. The three main aspects are pain, stiffness, and reduced range of motion and loss of use of the joint. So pain is dull, burning, or sharp, usually transient. Constant pain or pain is a sign that osteoarthritis is getting worse. In inflammatory arthritis, pain is usually relieved with movement. Stiffness is short as transient. Morning stiffness usually does not last as long as in rheumatoid arthritis, however. Also muscle weakness, not due to primary weakness of muscle, but because they don't use their muscles due to pain. We have swelling, which is usually limited. We have deformities. We have a reduced range of motion and loss of use of the joint. And we have also cracking and creaking. We have sleep problems also. Radiology. If any of the bold three are not present, we consider diagnosis. So the bold points are joint space narrowing, bone sclerosis, and osteophytosis. Joint space narrowing is characteristically asymmetric, as said. Bone sclerosis is a consequence of the typical osteoclast activation. Then we have also subchondral cyst or geode, which occur around joints where when synovial fluid is forced into the subchondral bone, causing a cystic collection of joint fluid. Erosions are centrally located, in contrast to the marginal erosions in inflammatory arthritis. This is particularly evident in the fingers, which are the joints we use to distinguish the possible arthropathies. Thus, rheumatoid arthritis erosions are typically lateral, because the synovial starts infiltrating the bone at a site in where the bone is exposed, so where there is no cartilage protecting the bone from the synovial-derived erosions. This is not the case in osteoarthritis. The central part of the cartilage is the one that breaks before. So, having rheumatoid arthritis is not a protective factor for having osteoarthritis. This means that if you have typical erosion of rheumatoid arthritis, it does not mean you should not look for osteoarthritis lesions as well. On the right, you see the typical involvement of the distal interphalangeal joints, the Eber-Dense nodes, which correspond to the X-ray we saw before. There are also nodules related to the proximal interphalangeal joint called Bouchard's nodes. They usually take place together. On the left, we see subchondral cysts. There are lesions that depend on the disruption and leaking bone, creating holes. In the holes, the synovial fluid enters, and depending on the architecture of the bone, it creates these fluid-filled cysts. Again, this is typical of osteoarthritis. Treatments at the moment do not interfere with the biological process of osteoarthritis. Here we see the comparison between osteoarthritis and rheumatoid arthritis. Rheumatoid arthritis usually begins between 25 and 50 years of age, whereas osteoarthritis after 40 years. In RA, we have an autoimmune response affecting the synovial membrane, which leads to the joint destruction, whereas in osteoarthritis, we have a biochemical destruction which leads to loss of cartilage matrix. Rheumatoid arthritis develops within weeks or months, whereas osteoarthritis develops slowly over many years. Rheumatoid arthritis is usually symmetrical, primarily affects small joints, may involve large joints like elbow, and instead in osteoarthritis it usually affects weight-bearing joints such as the knee, hip, lower spine, maybe uni or bilateral. Rheumatoid arthritis signs of inflammations are present, whereas in osteoarthritis the pain begins with the use of joints. Inflammatory signs are less common. Rheumatoid arthritis, morning stiffness often lasts more than 1 hour, whereas in osteoarthritis, morning stiffness usually lasts less than 20 minutes. Rheumatoid arthritis, we have generalized symptoms such as fatigue, weight loss, and anemia which may be present, whereas in osteoarthritis does not cause a general feeling of unwellness. Rheumatoid arthritis is more common in females, commonly found in both, whereas osteoarthritis is commonly found in both males and females. Rheumatoid arthritis, the osteophytes are absent, whereas in osteoarthritis, osteophytes may be present. In rheumatoid arthritis, rheumatoid factor is frequently present, whereas in osteoarthritis, rheumatoid factor is absent.